We thought we had this thing under control, so we stopped doing these live events. We thought the last surge was the last surge and there wasn't going to be another surge, but of course there's another surge. So tonight we gather again to do a COVID live event, to go over some of the therapeutics, to go over some stuff on PE, to talk a lot about compassion fatigue, which I know so many of you are suffering from, and crisis standard of care and many other things. But let's go to the slide. And it was Martin Luther King here in the United States yesterday. So this is one of his many quotes: "We must accept finite disappointment, but we must never lose infinite hope." A lot of us are feeling very fatigued. Those on the front line, those that are not on the front line, these are very difficult times. But we can get through this. We will get through this. We've done this before. We've got some new therapeutics. We've got some new things we can do. We're in a better position now than we've ever been, even though this feels like, really? We are doing this again? Unfortunately, we are doing this again. So I should shout out to This Week in Virology. I do this every time, but it's really important. This is a really, really important podcast. These are real experts, PhDs, MDs, mixes of MDs, PhDs, talking about this stuff in a lot of detail. If you really want to understand vaccines and viruses and how they work, not just COVID, but mostly COVID right now, please listen to this show. It is really outstanding. We've had Brianne Barker on here a number of times, who is on this show. She's fantastic. I want to talk about a few quick things before we get the show going. And the first thing is masking. I think there's been a lot of confusion now about masking. From the CDC, and you know, I really feel for the CDC. They're trying to do something which is very difficult, which is tell people how to look after themselves during a pandemic that's changing all the time. Initially, when they talked about masking, it was for source control. It was you put a mask on to protect the person near you, so that those droplets would be caught by the mask, so that they would fall to the ground, so that you wouldn't infect somebody else. Now, when they're talking about N95 masks, it's more about protecting yourself. So it is a little confusing, but if you do wear an N95 mask, you will protect yourself much better than a normal mask, and you will actually protect people around you more because of that filtration system. My one concern for the lay public, though, is if you have covered yourself in virus because you've walked through the supermarket and there's lots of virus because somebody coughed on you or near you, we need to tell people how to use an N95 mask, and you don't go home and take it off and wipe your hands all over it and then poke yourself in the eye. Those viruses are going to go into you. So we also need to do some stuff about how to doff those things as well. So I'm not sure that N95 masks for everybody is the right thing, but if you are immune suppressed, I'm talking to you out there that perhaps are not medically trained, that listen to the first part of this show, I think wearing an N95 mask right now is a good thing to protect yourself, but read please on the CDC websites and in our textbooks about how you take that off and then wash your hands so that you can do it safely. Now, Dr. Fauci has said, and many other epidemiologists, that it is very likely that we are all going to get this virus because of the infectivity, because this is a respiratory and droplet spread, because the R0 might be as high as 8 or higher. This could be the most infectious disease in all of human history. So we're probably all going to get it. But we do not all want to get it the same week, which could happen with a virus like this. So we are still trying to do those public health measures to flatten the curve a little bit. We're trying not to gather in big groups. We're trying to wear the mask. We're trying to get as many people vaccinated as possible. And we're already seeing, and you're about to hear from Jan Schonberger, just how bad it is right now. If we can just flatten this a little bit and spread this over a little bit of time, even if eventually many people, most people, perhaps everybody is going to get this, we need to spread it over a little bit more time. Now, one of the things that came up with Delta is if you got vaccinated, we were told that you reduce the amount of spread. If you had a vaccine on board, even if you got infected, your viral load would be low, so you are less likely to spread it to other people. This article and this article suggest that that is also true for Omicron. Maybe not as much as with Delta, but an initial study came out that wasn't very good that said, it's all bets are off, you're as infectious as everybody else. But these studies that are still in the peer review stage are suggesting that if you're vaccinated, your viral load will also be very low. Your chance of giving it to somebody else is also very low. So that is exceptionally good news. And lastly for me, I think a little bit about testing. I think we're in a bit of a cluster when it comes to testing. We need to understand these tests. We're about to send 1 billion tests to everybody in the United States and then just say, have at it. And I think that most people have no idea how to use those tests. I don't think most clinicians know how to use those tests. So just remember that PCR is ultra sensitive. You find a little tiny piece of mRNA and you cycle it up and up and up and you amplify it and you say that's a positive test. And we're seeing a lot of false positive tests. You've been infected a month ago. Your immune system, your vaccinations have killed the virus. and then you come to hospital. This just happened in our family a few days ago. Then you come to the hospital and somebody gets a great sample. They take that thing, give you a brain biopsy, and get those boogers from way back there from a month ago. That can turn positive, but there's no live virus there. So just remember that PCRs are ultra sensitive, but can give a lot of false positive results when it comes to active viral replication, which is what we care about. So much better than, and this is just sort of an article that goes over that, a positive doesn't necessarily represent that you have got a live virus. It's a very good test in some circumstances, but not in others. What's really good, if you care about the most important thing right now is, are you infectious, is antigen testing. Antigen testing at the right level tells you whether you are actively excreting virus. That means there's a lot of false negatives. So you could have the virus, the antigen test is negative, but you're still replicating virus. But they're very good for you're replicating virus at a high level, meaning that you can infect other people. So they're pretty good tests for that if they're done at the right time. And the right time is probably symptom onset for a few days or for maybe a day or two before symptom onset. After you get past those, your viral loads drop and they're not very good. If you wanted to know, was that infection that I had COVID? It's not very good for that. It's pretty good for whether you're infectious right now. And we have more and more data to suggest that is true even for Omicron. And then a lot of people have asked, well, why don't we just send tests to everybody, and is that as good as vaccination? If we test everybody and any time you're positive, you go into quarantine, is that as good as vaccination? And this is just one expert that says you'd have to test every single person in the world or in the United States or wherever you live every 3 days, and then you'd have to rely on those people to actually quarantine for it to be good as vaccination. So guess what? Vaccination wins again in terms of using it in the real world in terms of cost, etc. You're going to hear that a lot tonight, etc. So if you are getting these tests, and I just went on the CDC website, and it's a day early, but I actually ordered the 4 tests that I get free for my location. So every home in America will get 4 free tests. So once you get those, if you're not sure when to use it, this is a great site, whentotest.org, and you can go on there and answer some questions, and they'll tell you whether you should or shouldn't get a test right now. It is very complicated about when to get a test, so I'm hoping not everybody, when they get them, just shoves them up their nose and does the thing, because that's really not what you need to do. And so lastly, let's talk about the vaccinated and the unvaccinated. You know, I think we need to, very quickly after this wave goes away, get back to normal as much as possible. The problems with this virus extend beyond hospitalizations and deaths. The social issues here, the problems with schooling, this has really been a tragedy of the last 2 years. And if you're vaccinated and boosted and you're not immune suppressed, and we get past this period where we're crushing the healthcare system, then I think we need to get back to as normal activity as possible. Because if you are vaccinated and boosted, your chance of dying from this is extraordinarily small. It's not zero, nothing is zero, but it is very, very small. What we're seeing right now is a surge of the unvaccinated. Now, in the past when it was Delta, if you were vaccinated, the virus got to you and it stopped. But now, because it can go around your immunity a little bit, you actually can be a vector to other people. So that herd immunity was lost a lot. But in terms of your ability to go back and function in society, soon we should go back to where we were a few months ago before Omicron. Vaccinated, boosted, we're good to go, we can gather, we don't have to worry so much about this. If you want to read more, our textbook has a whole bunch of stuff. In fact, the chapter got so big, oh, excuse me. Okay. The chapter got so big, we had to divide it into pediatric and adult sections. And we got another chapter coming for MISC. I sound terrible, but I feel good. I'm going to throw to these guys. They're going to run the show tonight. Don't eat peanuts before the show.
And then we
Take
have
it away.
The Epsilon variant coming out, coming to a ER near you.
I
How are you
think
doing,
he just
Britt?
let out one of his secrets that chocolate peanut M&Ms are always
It was
stashed
a terrible
everywhere,
decision.
everywhere in the studio because it's Mel's favorite. I'm good. How are you?
Doing okay. You know, while Mel was talking about all that testing stuff, I just got like flashbacks from the future. You know how we had to do all the hepatitis serology for boards? Those,
yes.
I'm excited for the future generations that get to do the COVID serology memorization of some wacky tables.
I know it all takes about 10 years to get there, but soon in the upcoming 10-year boards. So one of the things Mel talked about in the intro was that it just feels like everyone is getting this, right? Like we avoided Delta, many of us did, but now everyone's getting Omicron. Do you think that's true?
Yeah, I mean, certainly in the places that I work, people that I know, my family, friends included. It just seems to be swiping through everybody.
So with that, Jan, is everyone getting COVID? Are we right?
Well, I have some bad news and some good news for you, Britt. Yes, it does feel like everybody's getting COVID. That is particularly true in the ED. So let me just do a little flyover of where we are in the world and where we are in the country in terms of rates of infections. So let's start with the world. Here's a map of the world, folks. And if you see those purple areas, those are areas that are basically hot zones where there are high rates of infections per 100,000 people. Now, you know, anytime you look at a map like this of the world, you do have to put some context around it, right? You have to be doing testing and have access to testing to actually have positive results. So, you know, whether or not this is truly representative of actual rates that are happening around the world, you know, put it in some context. But you can see that where we all sit now in North America, at least those of us who are on the Zoom at the moment, it's a pretty high rate of infection. So these are right now the hot spots in the world. And you can kind of take a look around. In Europe is hot right now. Australia's lighting up, you know, a little bit of South America there, and North America, definitely. All right, now we're going to move on to the United States. Again, a dark purple is a hot zone, and that pretty much is almost everywhere. If you were looking for the lighter yellow and orange, you wouldn't find too much of that on a map like this. So really, it is very, very widespread, and that is a reflection of how infectious this virus is and the access that we have to testing and the rate of testing that we're doing right now in the country. It's much different than it was certainly at the beginning of the pandemic. So if we look a little bit more locally here in Los Angeles, you'll see, I mean, boy, that upright curve, when you look at the testing positivity rate, that was about a week before Christmas that it really shot up. And we were a little bit behind New York City, as we often are. It came a little bit later. And the good news is you see that it really rose quickly, and it seems like the positive tests are starting to plateau. And that is the good news. If you look at hospitalizations, it certainly feels like things have gotten a lot busier for us. And you see at the far right of that curve that indeed rates of hospitalizations have gone up dramatically. But if you look a year ago in the winter where we were really underwater here in Los Angeles, we're not nearly at those types of levels. So that is also some good news in these sharp inclines upward. Now, some more good news. If we look at what's happening in New York City, you'll see that all the trends are in a decent direction. You'll see that really things are starting to come down. Yes, they're high. Yes, it's prevalent, but we are starting to go in a direction that makes us smile, which is downward. So that is for us, I think, on the West Coast, maybe a marker of good things to come. And we're all hoping that that will be the case. Next, this is the CDC looking at hospitalization rates. And again, if you look at the far right, you'll see that we definitely have an upward trend in hospitalizations, but we are coming down a little bit. And again, if you look to where we really were peaking a year ago in the winter, we are lower than where we were there. So that is some good news. And so finally, we get to the actual experience on the ground. And the truth is that this wave of the pandemic feels a lot worse than where we were previously. And because of all of us getting sick, and our technicians and our janitors and our nurses and all of us, it is really a different experience for all of us right now fighting through this pandemic. And here in Los Angeles, that has been very, very true. It's hit all of us very hard. And so while the experience, you can look at a map and look at rates of positivity and, you know, rates of hospitalizations, for us on the ground, the amount of patients that we're boarding, the kinds of things that we're seeing is really, really hard on all of us. And I know we're going to touch on that in this session. So I look forward to those comments. But it's been a bit of a tough experience, separate from all of the maps and the numbers. Britt and Scott, back to you.
Thanks so much, Jan. Definitely like those last two news articles that you posted, like unintended or even unanticipated consequences of this marathon, the blood supply shortage. I don't know if you've had any friends or people who sent emails, like hospitals requesting donations from staff to keep their blood levels accurate.
But I want to hang on to that slide that New York cases are going down. And I just really hope that reflects for what's going to happen hopefully soon on the East Coast and on the West Coast. Okay, so next we have to talk about a topic that I can't even pronounce. It's the therapeutics. And there are some new therapeutics out there. I think that's really, really helpful in combating the surge and knowing that there's some new medicines out there that are helpful, but I can't pronounce them. There's some Virs and some Mabs and a Plax or something.
Yeah, it's a Paxlovid. It's for COVID. Just they got the rhyme in there to help us out, But luckily, we've got some pronunciation experts, also experts in some other parts of medicine. We're going to throw it over to Sean Nort and Stuart Swadron for an update on these therapeutics.
Thank you very much. Yeah, that's fantastic. I have been spending the past 2 years trying to pronounce these, and I'm going to show off now. I'm going to go through. Look, I know I can say dexamethasone now. But let's. What we're going to do is we're going to go through just a quick summary on the first slide of what we have been doing and a summary of the drugs up till now, and then we're going to talk a little more in depth about the 2 new antivirals that everyone is hearing about and not necessarily being able to access so much, but we'll get into that. So Sean, I just want to talk about where we're at, just so we can summarize up till now. Dex and tocilizumab. See, look, I'm showing off. Sotrovimab and remdesivir. Where are we at with those?
Yeah, so hey, everybody. So we're not going to do as deep a dive as we've done before, but just to touch base as the ones that Stuart was talking about. So dexamethasone definitely has some serious benefit here. So it's the 6 milligram dose that's given every 24 hours for hospitalized patients with COVID, not ones that you're sending home who have an O2 sat that are requiring oxygenation, or ones who either require mechanical ventilation or ECMO. Tocilizumab, we were pretty hot on these early. This is an IL-6 antagonist. This is got an EUA for people who are on corticosteroids, right? So those are going to be your sicker patients, supplemental and oxygen, which is anywhere from just non-invasive to high flow, all the way up to ECMO if they're requiring that. And many of the intensivists, of course, we have the excellent Dr. Krager here who can weigh in, but if they have an elevated CRP, because you're trying to say, hey, who is the one who could probably benefit? So a CRP of 75 is usually thrown around and said, hey, maybe this is somebody who could benefit from tocilizumab. It's a single dose, 8 to 12 milligrams per kilo, up to a max of 800. And then you can repeat it if there's no benefit beyond 8 hours. So Truvimab is the only monoclonal antibody currently that is effective against Delta. So any of the other ones are not Delta. I apologize. Omicron. Gosh, they just keep coming, don't they? Omicron. So this is a single dose that's given as 500 milligrams, and these are for people who have mild to moderate, and they have to be confirmed. This isn't just suspected, and you want to start it within 10 days, but of course as soon as possible. And then finally, remdesivir. Remdesivir, it's really questionable how much of a clinical benefit it has, but it does have an FDA approval for this for patients that come in and have radiographic evidence requiring supplemental oxygen. So these are hospitalized patients, and it's given for 5 days, 200 milligrams on the first day, and then 100 milligrams for days 2 through 4. If they need to get mechanically ventilated, or if they're on ECMO, the recommendation is to continue that therapy because it's really indicated for those people that are not on those more advanced therapies. So Stuart, that's the update on the previous therapies. Now we're going to jump into the newer ones.
Right, excellent. And so I just remember the monoclonal antibody. It's the one that starts with S that works against Omicron.
Yeah, that's the easier way.
That's a better way to remember it. So moving on to the new antivirals, I just want to give props to Ruben Strayer we have there. He's sort of looking down at the slide in an approving way because he made it, so he better agree with it. But we're just going to go through these graphics, and the first thing, of course, is it's kind of like the paradox, who is eligible for these things, and then those that are eligible. It might be hard to get it. It's a little bit frustrating, but let's start off by talking about the eligibility criteria, just in general, Sean.
So the big difference between this and the SMAB that we just talked about is that goes out to 10 days. This is only for patients that are symptomatic 5 days or less. It's patients that are greater or equal to 12 years of age, greater than 40 kilos, have a confirmed positive COVID test, and are high risk for progression to severe disease and don't require hospitalization. As you already said, Stuart, so many of these patients that either won't benefit from it, don't need it, and then the ones who can are probably going to have a contraindication, and we'll jump into that.
Yeah, that's what I was trying to say. And of course, the obvious question, what is a high risk for progression? And we all kind of know what those things are, but there's been a lot of fudging around the edges that's a little bit concerning about that. So jumping right into Paxlovid, this is exactly the paradox, first of all, Sean's going to tell us about how hard it is to get a hold of in terms of what's been delivered and what you can get. You want to tell us about that first? Or?
Yeah. So, and probably everybody who's listening who's tried to get this drug for their patients, it's nearly impossible. The manufacture process is supposed to be very long, 8 to 9 months to make this drug. It's actually a combination of 2 drugs. So that's really one of the big problems. Paxlovid is a combination of 2 different drugs. It's nirmatrelvir and ritonavir. One's the true antiviral, the nirmatrelvir, and then ritonavir, as if you listen to Ruben's great piece, is to inhibit cytochrome 3A4, one of the very common ones that affects drugs. And that's really the rub here, is that those sicker patients are going to be on a lot of these medications chronically.
Yeah, so this is really the issue here, right? You take a look at this, even if we can get this without a problem, which is an issue to begin with. It's just so hard to get your head around the fact that by definition, someone who needs it is on these medications. So we're going to talk a little bit about it. We don't know all the answers, but we do have some suggestions. What do you do if they're on an antihypertensive or on a statin? We're going to get into a little bit of that. But the bottom line is that we don't know the answers to a lot of those questions, and it's going to be mostly on a case-by-case basis, I think, in terms of what they're on and what our strategy is going to be to deal with that. Like, are they on an antihypertensive? Maybe we can check their blood pressure more frequently over the next few days that they're on Paxlovid, and maybe it's not such a big deal as long as they're in touch with their doctor. Statins are probably not a big deal to be off for a few days. But even that's not enough information. How long do I have to stop it for? How many days do I have to wait? We don't necessarily know all those answers yet. Sean, do you want to add anything to that?
Yeah, I will. Before we move on, though, I do want to touch on the dosages. So the dosages are, they take 300 milligrams, so that's 2 of the 150 of the nirmatrelvir, and then 100 milligrams of ritonavir. So they're taking 3 tablets twice a day for 5 days. If they have a GFR less than 60 or above 30, then you're going to cut that down to 1 of the nirmatrelvir and 1 ritonavir. The question comes up, do I need to check labs? If you have fairly recent labs and you don't think anything's changed, I think that that's okay. But a lot of these are going to be sicker patients. So again, as Stuart said about the drug-drug interactions, you have to use your judgment there. As far as the drug-drug interactions, I mean, if you look, there are what they call true contraindicated meds. As you were saying, some in there, I think you could hold. Some of them you can't, right? So do you really want to hold someone's amiodarone, right? It's got a very long half-life, but you don't know. So I think you have to be careful when you look at that. And that might be somebody say, hey, even though they might benefit, because it does have a pretty good number needed to treat to have a benefit, and it prevents hospitalizations in like 89% of the people, at least if you trust the data that was there. But then they have the kind of relative contraindication. So you have warfarin is one. So make sure that person gets checked in and gets their INR checked, right? There's cyclosporin, tacrolimus. Both of these can be affected, and you have your transplant patients. But again, these are things that can be measured. So I think shared decision-making with your patients and then your clinical judgment on what to do, rather than just look at the list and say an absolute yes or no for it. Because I think if you follow the list to the T, really no one's going to get this drug who might actually benefit from it.
Yeah. That's good. And there's a few other questions that we'll try to get to when we're done about details. But again, like Sean said, we might not know the answer to these yet. So moving on to the other drug. Let's call it that. Let's move on to the other drug. And molnupiravir got approved, of course, first. And I'm not so sure that the same thing would have happened if it had been. If Paxlovid had been approved first, maybe it wouldn't have been approved because it's so much less effective. And so the less effective drug is more available as it turns out. You've got the dosing information there. This is what people are using. It's out there. What do you want to add about that, Sean?
So there's a couple of things. So actually, yeah, the word on the street, it's funny, I was reading some New York City data that, that people are like, I don't want this. I want Paxlovid, right? Because people, read the data. There's a couple of things that are concerning about this. Molnupiravir, there is at least a theoretical concern that this can increase resistance to COVID. So we have to keep that in our mind. This is similar to HIV. The mates are used very much the same, that this can happen with that too. So there's a chance of resistance, and then pregnancy and breastfeeding, including men, right? You have to worry about if you're a man with this, because it's been suggested in animal data to have skeletal deformities from this. So anybody who's pregnant, at risk of getting pregnant, who's actively trying or breastfeeding, it's recommended not to use this. And for men, that they're not supposed to have unprotected intercourse for 3 months after
3 months. 3 months.
So
right.
this is something to really discuss with your patients before this is prescribed.
Right. Okay. And so hopefully we're going to get some feedback on people that have been using these drugs, because I haven't prescribed them. And that, I think, is a wrap. That's the new information. And we can hand it back to the desk.
All right. Thank you.
I think Swami actually wanted to cut in really fast and make a comment.
Yeah, I just had a couple of quick things. So Sean and Swad, thanks for going through that, because I think there's a lot of questions about those drugs. There's a couple of things we need to remember. Molnupiravir, we actually have published data on it. So while it has a less of an effect on hospitalizations, it at least has data that we can see, whereas Paxlovid, no one's seen that data. And there's a lot of calls to say that if we're going to be prescribing a medication, shouldn't we see the actual data instead of just a press release? So I think that's something to think about. We don't actually know how good Paxlovid is without seeing that. And then there's a lot of questions in the chat about fluvoxamine, which I think we've talked about a couple of times. Maybe we haven't gotten into it as much as we'd like to. Fluvoxamine is an old drug. It's an SSRI. It's pretty cheap. I've never written a prescription for this drug before, but we are seeing more of it being put out there for COVID. I think a lot of that is because of this study called the Together study that looked at it. But I think, again, we have to take a little bit of caution with this, because in that study, what they actually found a reduction in was ED observation greater than 6 hours. Not even hospitalization, no difference in hospitalization. So fluvoxamine, it sounds pretty good and it's cheap, and apparently it's readily available in a lot of places, but I don't think we quite get the bang for the buck that we would like to see with that. So I'm not convinced that fluvoxamine is a game changer by any means. Sean, I don't know if you have specific thoughts on that drug. I know there were some questions about mechanism and why an SSRI would help. Maybe we just feel better about having COVID because we're on fluvoxamine. I'm not really sure, but I'm sure there is an actual mechanism there as well.
There is. So just before I forget, you're absolutely right, because that is the big problem with Paxlovid, is we don't have that data. And there is the New England Journal study, right, is the larger study with the molnupiravir. So really appreciate you bringing that up. That's why we focused on, when Stu and I did the update, those are really the ones that we think have the strongest data, because you can go through all of these, including fluvoxamine, and I just don't think the data is there to support it. We've gotten, actually a recent one that we got was about inhaled corticosteroids, that there may be some benefit from that. Clearly, the inhaled corticosteroids are beneficial with people who have pre-existing asthma or COPD. Very unclear if you do not have that, if there's benefit. So unlike a year ago when we were really kind of pushing the envelope a little bit with kind of exploring some of these, we really were trying to be with both feet on the ground, grounded. And I just don't think the data is there to support fluvoxamine at this time.
So, Sean, if I remember correctly on those inhaled corticosteroids, it's a reduction in cough. It's a reduction in symptoms. There's no change in whether the patient needed to be hospitalized or if they got worse, if they got sicker. It just might have relieved cough a little quicker, which, I mean, I would kind of suggest 2 teaspoons of honey might do just as much.
I agree. If we look at some of these clinical outcomes, remdesivir, very much the same, right? If you look at some of the clinical outcomes, there's this scoring system, and, it's just, so yeah, statistically significant, as everyone knows, doesn't mean clinically significant. And then even when you said, even if it is quote unquote clinically significant, is it something very minimal, as you're suggesting? So yes, I agree, Swami.
So there's some questions about Paxlovid in terms of the timing. And if you read the manufacturer press release, the best I can work out, it was effective in the first 3 days, but then I think there was a subgroup that they tested at 5 days and said it looks like it was as good as the 3 days. But I find it very confusing. I've read it about 100 times, and I have early onset dementia. But can somebody younger and smarter speak to that? I think that's what they did. It was really a study of 3, but they did to 5 and said it looks the same. But we, again, don't have the data, so we can't really go into it.
Yeah, I don't think I'm smarter than you, Mel, but I will say you're right. And so if you had somebody that you were entertaining using this for, I would say the earlier the better. I think that 5 recommendation is kind of pushing it a bit. So yes, you're correct with your interpretation of the data.
Well, thank you guys so much for that. I know there's a whole bunch of questions right now in the comments on the live chat. Keep throwing them in there. We're going to continue to review them, send them out internally so we can get those answered to you. It's the easiest way to communicate with us in between segments, anything that comes to your mind. And obviously, we'll continue to try to update you in the chat itself. But for right now, we're going to just table the discussion on therapeutics for 1 second while we get some of these questions answered. And Britt, you actually sat down with Annette Decker to talk about a very difficult topic as well that has unfortunately kept coming up and up again, right?
Yes, crisis standard of care. And it's going to be pretty amazing. I'm going to be in 2 places at once wearing the same outfit.
It's the movie magic of
Weird.
Hollywood. Let's check it out.
All right, everyone. So we have covered this idea of crisis standard of care actually last year in an EMRAP live show. And I think many of us were actually hoping that we never would have to talk about this topic ever again. However, we unfortunately are finding ourselves in a pretty intense COVID surge right now. We're short-staffed, we have no beds, and I think this idea of crisis standard of care is probably a really important one to talk about again. So to talk about that and answer some of our questions on this really tough topic is Dr. Annette Decker. She's actually one of my colleagues and the research fellow at UCLA. So welcome, Annette.
Hi, Britt. Thanks for having me.
So I think let's just start with, could you kind of define crisis standard of care again for us? Maybe some of us missed your last talk, or we just don't quite remember what exactly it means, but could you just kind of define what this crisis of standard of care really means?
Yeah, absolutely. So a crisis standard of care is really an operational plan that is implemented in a health system, usually on a regional or state level, when there aren't enough resources to provide the normal standard of care. And so often we're talking about that now in terms of the COVID-19 pandemic, but you can really think about this in terms of any situation that is straining resources. So a natural disaster such as a earthquake or a hurricane would apply as well.
So since you and Mel actually talked about this last year, have there been any states that actually had to implement these protocols?
Yeah, there's actually been 4 states that activated their crisis standards of care. So Arizona and New Mexico activated their plans actually back in July of 2020. This was interesting because the state activated the plan, but left the decision of whether or not to triage ventilators to the health facilities themselves. And ultimately, it seems like none of the facilities actually needed to triage the ventilators, which is great news.
Yeah.
So more recently, Idaho and Alaska activated their crisis standards of care just in this prior fall. We're still waiting to see what the data showed from their activation of those plans. We're not exactly sure what was triaged and what the outcomes are, but I'm looking forward to seeing what those states actually did.
So in terms of when a state actually decides they need to implement these crisis standard of care protocols, how do they decide to actually activate these protocols that are in place?
Generally, crisis standards of care have very specific triggers of when a healthcare system should move from their standard care to their contingency plan to their crisis plan. And examples of these triggers include bed capacity or ICU capacity or number of ventilators. But the reality is that we're seeing that this trigger is a lot less black and white than we expected it to be. And this is for a number of reasons. One, how hospitals report bed capacity actually varies quite a bit. And until we have some kind of standardized way of reporting, it's very hard to understand what is actually happening on the ground in terms of capacity. Two, there seems to be hesitancy in terms of public health officials actually activating these plans. And so the reality is that I think a lot of us are seeing informal triaging of resources. So we're practicing waiting room medicine, or we're providing ICU level care in a non-ICU level environment. And I think this is really important to think about, because when that happens, the level of care that you're able to provide is really dictated by the resources that your individual hospital has, rather than the resources that are available more broadly on a regional or state level.
Now, I actually wanted to ask you a little bit more about that because I recall when you and Mel were talking about this crisis standard of care last year, you were really talking about it in the context of critical care resources, ICU beds, ventilators. And I think now, as more of us move through this current surge, yes, the ICU resources are limited, but also just bed availability. You mentioned that we're doing waiting room medicine, things like that. Does the crisis standard of care protocols address the care that we are providing to both COVID and non-COVID patients and not just critical care, or is it really just focused on critical care resources?
Yeah, that's a great question. So honestly, crisis standards of care are designed to apply to anything that is scarce. So that can be an ICU level bed, but it very much can also be just overall bed capacity, or it could be PPE, or it could be staffing. And so really when we're thinking about these protocols, they should be quite limber and really should be able to be applied to a variety of situations. But I'll note on that, and this is something Mel and I talked about last time, it's important to keep in mind that the triaging of the resources is relevant to all patients, not just patients with COVID-19. So
Mhm.
if you're talking about not having enough beds or not having enough ICU beds in terms of who gets care, it's not just which of these COVID patients, it's also your GI bleeder or your septic patient or your trauma patient in the other rooms that we're thinking about in terms of who's getting resources. And I think this is particularly relevant right now. I think, at least anecdotally, we're seeing
Yes.
a lot higher levels of high acuity that is not COVID related compared to where we were a year ago.
So one thing I wanted to bring up is this idea of the SOFA score. And I know that you and Mel talked about it last time. And if I understand it correctly, it really just means if you have a patient with a really high SOFA score, they have a high risk of mortality, and they likely are not going to get some of these critical care resources. Has there been any updates in the literature to suggest that the SOFA score is helpful, or is it still just kind of maybe not the most useful metric?
Yeah, Britt, honestly, I'm not sure anyone likes the SOFA score, but somehow it keeps coming up in these crisis standards of care. So currently, 48 states have a crisis standard of care, and of those states, 40 rely on the SOFA score as the algorithm to determine who gets scarce resources. And as you appropriately explained, the idea is that if you don't have a lot of resources, we should be giving it to the patients that have the best chance of survival if given those resources. And the SOFA score is supposed to be that proxy. But in reality, we're seeing that the SOFA score really isn't a good indication of mortality. And we've actually now had some time to look at this with COVID patients. So, just keep in mind the studies that have been done, they have some methodological challenges given that it's all done retrospectively. But there's a study out of Arizona that looked at about 700 patients who had COVID, who were intubated, and they measured their SOFA score right before intubation, and then they tracked mortality. And ultimately, they saw that the SOFA score was really not at all predictive of mortality. And something like age was actually a much better predictor. So a lot of concerns in terms of how this is being used and how it's being used to prioritize care.
Now, again, when you and Mel had chatted on this topic last time, you had mentioned that you had some concern that a lot of these crisis of standard of care protocols and algorithms may actually exacerbate healthcare inequalities that already exist. Has there been any research regarding this specific topic within the idea of crisis standard of care?
Yeah, Britt, I'm glad you asked. This is still a very real concern. So, as I mentioned last time, there's concerns that the SOFA score and comorbidities are potentially more so a marker of historical inequities rather than real-time mortality. So part of the SOFA score involves creatinine level, but it does not take into account what baseline levels are for patients. So for example, then patients with CKD, which historically are more marginalized patients, might not be getting access to resources because the SOFA score would predict that they have higher mortality, which might not be true. And now we actually have several different researchers looking into this question, which I'm very glad because it's a very relevant question. There's a group of researchers out of New Haven that looked at about 2,000 patients, again, in the height of the pandemic with the first surge. And they looked at everyone who was COVID positive and they estimated SOFA scores similar to the other study that we just talked about. And what they saw is that patients who are Black, not Hispanic, had higher SOFA scores, but had the same levels of mortality and ICU admission compared to their white counterparts. And I just want to pause there for a second. This is important. So if we are using the SOFA score to determine who gets resources or to potentially systematically deny resources to certain patients, this group of patients might have been denied resources because of the higher score, despite the fact that in reality, there was no higher mortality and no higher levels of ICU admission. So this is a problem. We really need to keep looking at these issues and try to come up with an alternative method to triage. Otherwise, we're going to exacerbate already existing health inequities.
I'm glad those researchers are out there doing those studies, because I think that's really important. And like you said, they're already marginalized populations, and then to not allow them to have access to some of these really important resources, I mean, that in and of itself is going to increase their mortality. So, all right. So just as we're wrapping up, any other thoughts or concerns or anything that we didn't cover, maybe that has been updated since you last spoke with Mel?
Yeah. You know, honestly, it's a very tough situation to be in for all of us. I think kind of reflections that I've had over the past year as I continue to look at this data. One is that we really should be thinking about transfers prior to any activation of crisis standards of care. So, you know, ultimately, I think what we're seeing is there are regions or hospitals that potentially have more resources and that we could be doing more load balancing prior to getting to the point where we're activating real rationing of care. Second, I can't emphasize enough, let's do away with the SOFA score. Let's find another way to try to triage resources. And obviously that's going to be a joint effort to find alternative methods that are more equitable. And that's really kind of the last point that I want to make here is trying to find ways to develop these very challenging protocols and challenging situations that truly incorporate and promote health equity and take in the opinions of the communities that they're actually serving.
Awesome. All right, Annette, thanks so much for taking the time. And hopefully we don't have to talk about this particular topic anytime soon.
I agree. Thank you, Britt, for having me.
All right, so there have been a lot of really awesome questions and chats going on in the YouTube chat. So we want to take a second just to address some of those. So Scott, what's our first one?
Absolutely, Britt. So the first one's actually a great question. Jan, I think you have some expertise on this. Something we're doing at our hospital, right? So patients that come in, they're hypoxic, look really well overall, need a little bit of nasal cannula maybe to perk up. What are we doing with those patients? Is there a plan to maybe discharge them home with oxygen? Is that something that we've had some experience with? Is it going well? And we give those people dexamethasone if we send them out with that little bit of home O2 to keep their sats nice and high.
Yeah, so we did start a protocol on sending patients home with home oxygen. Basically, if they required 3 liters or less by nasal cannula and they otherwise were doing well, we would send them out with home O2. Now we had we have specific criteria. They need to be statting at least 92%. They get a phone call from a nurse the next day. So we do have sort of a built-in hospital protocol for this. They go home with a pulse oximeter. They watch a video with some very specific instructions about when to come back. And we published a paper, I'll put the link of it in the chat, about the safety of this, and it also outlines our protocols. So resources for anyone who's considering starting a program like this. And in terms of dexamethasone, the CDC recommends that if someone has a new oxygen requirement, that you can give dexamethasone up to 10 days, basically for the duration of while they need their oxygen. So we do that as well.
I think that's so important, is having the criteria for who is even eligible for the oxygen and then having that follow-up plan. Mel, one of the other questions that came in was actually just what Annette and I were kind of talking about, is this crisis standard of care. And the question really is, if you document that in your medical decision making and you say, this care, this is what we did, this is what we provided in the setting of a crisis standard of care, does that protect you legally?
Well, I'm no lawyer and I do not play one on TV, but crisis standard of care usually has to be regional, on a county level or on a state level. The governor has to say we are now in a crisis standard, the standards have dropped. So you yourself can't state, and this is I think the most important thing, you can't decide, the hospital's really a cluster right now and there's 50 in the waiting room, I'm declaring a crisis standard of care. You can't do that. But I think you can, and I think it's smart within the chart to describe what's happening at that time. Simply because when that is read, for example, by an expert, if you got litigated, that would help them understand, well, what was happening then? So you can put, we're in the middle of a pandemic right now. You could probably just look up the date and work that out. But I have heard legal experts say it's not necessarily inappropriate to describe the current situation. If a plane crashes outside your hospital and you're about to get 700 patients, you're not going to be able to provide the same level of care than if it was a car crash with 2 people. So explaining that in the chart is probably going to give you some significant protection. But don't just state, I've decided not to do stuff because things are really bad right now. You can give some color, but be careful how you do it.
It's your dot phrase, more than 10 people in the waiting room, crisis standard of care.
So we can't declare crisis ourselves. I guess that's the important point. Although sometimes I feel like I definitely want to.
Swami, we got a question for you. Really great question from the chat. So we know earlier in the pandemic with other strains, we were seeing rates of myocarditis, other complications, figuring out who to work up and when for some of these complications. But the general feeling is maybe not as many people with the Omicron variant might be having these complications. We're not seeing as much of it. What do we know about that?
It's interesting because myocarditis, pericarditis is one that people are really keyed in on. Are we getting a lot of that with the current strain of COVID? I think the honest truth is we don't know yet. We're still collecting data. We need to get more data before we can make that decision. I am seeing a lot of patients who have chest pain with Omicron, but they're not bumping their tropes. Their EKGs are pristinely normal. These are mostly patients who are vaccinated. So I haven't seen a case of COVID-associated myocarditis with Omicron, but that's just one provider. We really need to get a lot more data before we can make that decision or whether that's happening. What we do see is a shift in symptoms. I think we've talked about that a couple of times. A lot more of stuffy nose, a lot more sore throat. And like I said, I've been seeing a lot of what seems like a musculoskeletal chest pain.
Okay, one last question from the chat. This is for Sean and Stuart. What are your thoughts on a 4th vaccine?
Oh, that's a very good question. So they've been playing with that in Israel. I shouldn't say playing with that, but they've been implementing that and they've been studying that in Israel. And we do have some broad strokes of data. What it seems like is that when you give another booster, you can generate another big peak in antibodies, very similar or more than you did with the previous booster. The question is, to what purpose and what exactly are we achieving by that? And in fact, in what I've seen so far, it's not particularly effective at preventing Omicron infection to begin with. Now, there is that period in there, that golden period, right, that we've all heard about, maybe the 10 weeks after the shot when you have those very high antibody titers where maybe you can prevent actually getting ill. And what we really don't know is, how when do you stop? I mean, what do you keep giving shots to people to have this high level of, and it's ridiculous, right? You're going to induce some immune disease, you figure. And so what we really don't know is what's underlying that antibody response. What are the T cells and what are they doing? And is this one of those vaccinations that's going to be a set of 3 that really get you as good as you can be? You're still going to be susceptible to those infections, but they're not going to be severe and life-threatening. Is that going to be the way this is going to pan out? We don't know the answer to that yet, but certainly they're not that excited about it. They're not forging ahead in a huge way. Guns blaring with another bad analogy there. They're not forging ahead in a big way with the 4th dose for everyone, and they're really taking pause, wondering about these same issues.
Yeah, I would agree with everything that you said there, Stuart, because, of course, the question of the T cell immunity, I could see forecasting, though, as we get more variants, particularly if there's big genetic little drifts of these, that maybe there'll be some further development. But as you're saying, clearly with Omicron, it's not showing that it's decreasing breakthrough infections, maybe severity, but those are people who've gotten, a lot of people have only gotten 2. Some people have only gotten 1. Right? So not everybody's gotten a 3rd dose. So yeah, the 4th dose really raises a question, and it'll just have to be studied. But the in the back of our minds, there's always, is there going to be a detrimental effect from just keep every 3 months, giving somebody another dose.
I think we're much less likely to be pounding and pounding and pounding again with this same vaccine than we are to have a specific annual updated vaccine like we do with the flu. That's a much more likely scenario, I think.
All right, guys, sorry, we got to move on and transition to our next talk. And this is with our favorite Dr. Sarah Kreger. Now, Sarah, we made a bet that you weren't going to be able to say it's complicated. Can you do it?
I mean, it seems really unlikely at this point. I will do my best because this is going to be a whole deja vu all over again, because I feel like we just did this. I wish that I could say, coming back this time, I can now tell you, what, a year later, that we have a magic number for you. Unfortunately, we do not. There is still no magic number. Yeah, we've all been looking for a nice magic number. We all have been not finding a nice magic number. The only good news about magic numbers is that the number of people and organizations trying to decree that you should be intubating at a particular magic number has decreased. I feel like before people were saying things like, okay, if the FiO2 is greater than 60 and their SAT is less than 92, then you intubate, or whatever random number people were choosing. Now people are saying stuff more like, if there's a persistent need for high FiO2 not otherwise specified, increased duration and depth of desaturations not otherwise specified. So still no magic number. Apologies for that. Now, it would be nice if we even had some really solid data on, are we harming people by waiting too long to intubate? Are we harming people by intubating too early? Unfortunately, the data there is also super unclear. There have been 2 really big studies, a big retrospective trial, a big meta-analysis that showed no difference. That being said, the one that came out like a week and a half ago was like, there's a big difference and we're all intubating too late. It's not clear. And nobody really knows, because not only do the definitions of what early versus late mean have changed quite a bit, those are all different depending on the study you look at. It also makes a big difference that there's a big difference between saying early versus late intubation versus indications for intubation. So since the data is so unclear on early versus late, I don't really know what to tell you. Is 48 hours from admission too early or too late? I don't really know. What I can say is that overall, I think everybody's beginning to head away from a clearly defined, if they're satting X on an FiO2 of Y, you intubate at Z point. Instead, I think we're heading back in this direction of relying on the good old clinical judgment. So I have written down for you my own personal COVID intubation decision factors. Big caveat here. These are my own personal decision factors. And they're my own personal decision factors today, January 18th, 2022. If we do this again a year from now, they may be totally different. But here are the things for me that make a big difference. The first one is there something else going on? Is there an alternate reversible cause of respiratory failure, right? Are they an asthmatic? Haven't been getting nebs because, oh wait, we don't want to nebulize COVID. This has happened numerous times to me. Are they volume overloaded? Do they have CHF? So just going back and just the usual suspects, the idea that, increased work of breathing and respiratory failure must equal COVID, that Venn diagram is not 100%, right? You can totally have a true unrelated. So if there's a reversible thing I can fix, let's fix it. Once I've checked off that box, the next most important thing to me is work of breathing. And I'll show you in a minute a couple of examples of what exactly I mean by work of breathing. But overall for me, that has become the single most important variable that I care about. Now, that being said, you got to put it in context, because probably the second thing I care most about is their overall trajectory and rate of progression. Because if they look, bad, but less bad than they looked before, fantastic, or at least I'm less concerned. Also, there's this rate of progression thing. And it's interesting because I'll see some patients who are sitting there and they've been satting like mid 80s for a while, then you come back 3 hours later, 24 hours later, 72 hours later, and they're kind of just hanging out and saying hi to you. Then there's other patients I've had where they start in the same place. They're not working that hard. They look okay, satting high 80s. Then you come back 2 hours later and they look awful. And so, I can't explain why some patients do it this way, other patients do it the other way. But those two things have also become very important to me. And lastly, and this, at some point gets back to what they were just talking about in terms of crisis standards of care, but you have to do a risk-benefit calculation here. And that context is both the context of the patient I'm talking about. Do I have a 98-year-old female with every medical problem known to man, or do I have a 22-year-old female who's doing great? At the same time, what is the context in the hospital system I'm working at? Are there 80 patients intubated in the ICU and just like intubated patients all over the hallways? Or is the ICU doing okay? There's intensivists, they're around. How many 20-year-old patients do I have lying to get intubated? So I think you just have to think about the patient context as well as the hospital system context. And it's complicated, but right now, honestly, for me, our biggest resource for these critically ill patients, it's not ventilators, it's not ICU beds, or at least not the physical beds. It's ICU nurses and physicians and respiratory therapists, because if we are overwhelmed, we cannot do a good job. And so the context that I'm making that risk benefit in, if I have a patient in a place where everybody's overwhelmed, there are no intensivists, I think about that when I'm deciding the risk versus benefit of intubating them. Now, let me go back to the work of breathing issue, because as I said, this has become the most important thing to me. And I've actually started taking some videos of this and showing them to the nurses and the respiratory therapists in my, step down unit or in the ED, and saying, I can't tell you to call me when X happens, but like this, if you ever see this, I'm really worried. When we talk about work of breathing, I think most people say respiratory rate, and that's fine. But again, that's a number. And the respiratory rate to me is not the most important indicator of work of breathing. The most important indicator for me of work of breathing is accessory muscle use. So I've taken a couple of videos, and this first one is of a patient that has a beautiful accessory muscle use because he's really, really thin and you can see it. Now, when I'm looking at this, that makes me very concerned. And that, if I see that, I want to intubate this patient as soon as possible. Now, the interesting thing about this patient is that his respiratory rate was actually not that fast. He was breathing like 20 to 25 a minute, but his accessory muscle use was awful. His oxygenation, he was satting like low 80s and he looked awful. He was diaphoretic. I intubated him right away. But again, it wasn't the respiratory rate, because if you just looked on paper, if you just looked at the documented vital signs, you'd be like, he's breathing 24, 25. That's not so bad. But then if you look at the patient, you're like, nope, that's not so good. And this was a patient where I actually came to see him because one of the nurses that I talked about this with them actually called me and was like, look, the numbers hasn't changed, but like he looks different. This is bad. Can you come see him? And we intubated him. Now, it's easy to see in patients who have that body habitus, but you still can see it in this next patient who has a different body habitus that makes it harder. And this patient was on BiPAP, so it's harder to see in this guy. But you can still see those accessory muscles. He is working. And this guy was tachypnic at like 60. So sometimes this accessory muscle use and the respiratory rate go together, but not necessarily. Don't be fooled by that documented respiratory rate. It may not mean what you think it means. This guy was another guy. I intubated him pretty much immediately. And so the work of breathing, it makes me really concerned when I see that kind of thing. And even if the patient is still saying, I think I'm okay, I think I'm still breathing okay, because sometimes it happens that your objective assessment of their work of breathing and their subjective discussion of their work of breathing don't always align. Sometimes your assessment of the patient's work of breathing and their oxygenation don't align in both directions. And so I find myself so often in the situation with these COVID patients when not all of these things are telling me the same thing, that the data I'm really relying on is if I don't have an alternate cause of respiratory failure, their work of breathing and accessory muscle use is getting to be concerning, and I'm not loving their trajectory, or even if they're still looking okay, but their rate of progression is concerning me, then I try and put it in my risk benefit context. And those are the things that will push me towards intubation sooner rather than later. So that's where we are at the moment, or at least that's where I'm at the moment. And what I will say is that, again, most people, if you start to read some of this literature, are saying, well, probably not a number, clinical gestalt, and so forth and so on. So overall, I think that's where people are moving.
Awesome.
So that didn't sound complicated at all.
I didn't say it once, Britt.
Won the challenge.
One time. All right, nice. So what do we have next?
Yeah, this is a great time actually to transition. If you're following in the chat, a bunch of questions already been popping up about this topic. We have Swami here, going to talk about PE and anticoagulation. Who are we anticoagulating? Who are we chasing this diagnosis in? What do we got, Swami?
I'm going to make it really super simple because it's not complicated at all. I want to start with the prophylaxis stuff. For if you're admitting a patient to the hospital, we know we should be giving some VTE prophylaxis. We've now got a couple of different studies telling us if they're going to the ICU, just regular standard dose prophylaxis is probably the right general move. Whereas if they're getting admitted to the floor, they might actually need a higher dose, almost like a therapeutic dose of anticoagulation. And I would say not the decision we need to make, but more of a discussion that we should have with our intensivists, our hematologists, if we have those people, and come up with a protocol to do that. Right now, I'm just giving standard prophylactic doses for all admitted patients, whether they're going to the unit or to the floor. The exception, of course, being the patient has a prior VTE, or of course, we've worked them up and we found either a DVT or a PE, then we're giving them therapeutic dose. There was also a couple of questions about sending people home and if we should be sending those outpatients with anticoagulation. And we also do have a little bit of data here telling us, no, you probably shouldn't do that. The one study that we have that looks pretty high quality says, if they're well enough to go home, don't send them on aspirin, don't send them on a DOAC, doesn't really seem to be much benefit. Again, the exception would be that patient who has a prior VTE history but isn't currently on anticoagulation. I might talk to their doctor and put them on a prophylactic dose. That might be the right thing to do, but for all comers, you don't need to do it. Now let's talk about the PE, because the patient comes in, they have COVID, they're short of breath, they're hypoxemic, and we've been going on about this for 2 years. Should I work all of these patients up for PE or not? Early on, it was kind of nice because we said, well, if they're really sick, you're going to put them on therapeutic doses of anticoagulation anyway, so don't worry about working up that PE. You're going to put them on therapeutic doses. It doesn't matter. Now we're saying, we probably shouldn't be doing that, and it brings up that question again. Who do we work up the PE in? Can't use a dimer. We know that any patient who's sick enough to come to the hospital, they almost always will have an elevated dimer. It's not universal, but it's pretty damn close. So I think we really have to look at making this decision on the individual basis. Is the chest x-ray matching with their clinical picture? So if the patient's got an oxygen level of 62, 63, 70, whatever it is, but their x-ray looks pristinely clear, that's a patient that I'm really going to be thinking, maybe I do need to get that CT angio and look for a PE. Obviously, if they have a history, if they've got any risk factors, if they've got a lower extremity swelling, those patients we're going to probably chase down PE in as well. It's all of those other patients where, well, their x-ray looks kind of crappy and they're kind of hypoxemic and they're kind of working hard to breathe. Do I need to work them up for a PE or not? I don't think anybody has the answer. I don't think anybody has a clear-cut, this is the way to do it. I think instead you look at that patient and say, we have enough experience with COVID now to look at that patient and say, is COVID explaining this? Is this fully explained by COVID pneumonia? Or do I think this patient is too sick and I'm worried about something else? Obviously, if you get a rapid test in your emergency department and it's negative, that might push you more towards getting that PE study, understanding the limitations of our tests. That's something that I would use to say, okay, I thought they were COVID. The COVID test is negative. Maybe I need to chase down PE. I think that's another place to think about this. So we don't have a good, solid answer on this. The things that I think we do have a good answer on is if you're admitting them to the hospital, put them on VTE prophylaxis. You don't need to be going with full dose anticoagulation in most patients. If you're sending them home, don't send them home on anticoagulation unless, again, there's some other specific risk that you're worried about that patient. And then as far as working up PE, do all patients need that workup? No, but I think you have to look for, does the clinical scenario match with COVID, or are they sicker than they should be based on the numbers I'm seeing or how they look? And maybe I need to actually get that PE study.
Thank you so much, Swami. That's really helpful. It's kind of nice how both of these clinical topics kind of circling back on the idea that using your, clinical reasoning and thinking skills and, in light of all the experience we've had, don't forget what we've learned. So.
Yeah. And I mean, it's just a tough topic in general. I mean, everyone with COVID is short of breath and tachycardic and has chest pain. So do you scan everyone? Do you just anticoagulate? I think, Swami, you lay out a really helpful way to think about this. So as we wrap up, we are going to have one more segment, which I think honestly might be, in my opinion, the most important segment and piece that we talk about. And that's compassion fatigue. We have all gone through how many waves of COVID surges and how many conversations with our loved ones that won't get vaccinated. And it's tough and it's exhausting and it's emotionally really draining for a lot of us. So without further ado, we have Dr. Beth Watson to talk about compassion fatigue.
So I've been talking to a lot of ER docs lately, and they have got what I'm calling, and I think it's a real term, compassion fatigue. We see patients all the time that smoke and are obese and have a heart attack, and we have a lot of empathy for those patients because we're all human and none of us lives perfectly. But in a situation where we have thousands of patients coming in with a preventable disease that they are dying of and a preventable disease that they are spreading to other people because they will not get vaccinated, I hear a lot of doctors just very fatigued. They're angry at their patients. And so I thought I would bring on Dr. Beth Watson. She's a clinical psychologist to help us perhaps with, is there anything we can do? Are these feelings normal? Are there any tricks? We are really suffering through this. It's really a problem.
Absolutely, I can imagine. So gosh, I hope the feelings are normal because I have to admit, I have some of those same feelings myself, and I'm certainly not on the front lines as you guys are and your listeners. I think a lot of us are feeling different emotions related to people's different choices about their medical health and what they're choosing to do and how that impacts the rest of us. So I think, actually as a therapist, I think all feelings are normal and allowable and something we should work on accepting. But certainly I think the emotional component of what you're describing, Mel, is frustration and anger. And so those emotions are helpful emotions, just like all emotions, and powerful. They can lead us and help us. And I guess I would encourage you to think about, how can you express those emotions, or what can you do with those emotions that's more adaptive or more acceptable? And so, one of the things your organization does, which is incredible, is offers a way for docs to connect, for medical workers to connect, to hear each other, to collaborate. And I think that's a really huge way, a wonderful way that you can help support each other by just talking to each other about it. I wish that you could all make more space for that. So maybe after a shift, before a shift, slowing down, checking in, kind of venting, and also hearing how it's impacting other people that are experiencing some of the same feelings. So I think it's normal. I think it's kind of par for the course right now, sadly. And, I hope you all take the time to express it.
Okay. The other thing you said before is, but you're a bit reticent to talk about, is like self-care. Self-care when you're in the middle of a pandemic and everybody is sick and you are doing extra shifts, but still it's an important thing to hear. I'd like you to say it again.
Yeah, no, so obviously it's like super important. I think it's a term that's a little bit overused right now. I feel my own hesitation is that I think, you guys are doing so much. And then I'm also like, oh yeah, and can you also do some mindful breathing on top of that? Can you also, take some time for yourself to do something that feels good? It's like something that you need to do to exist and get through this tough thing. And it's also more time and more investment of time. And so I guess there's some like guilt on my part for asking for that. I was sharing with you before, Mel, like I know for myself as a therapist, at times I might feel some compassion fatigue, or I might feel burnt out about, oh, I feel like I've told this person and we've talked about this issue and it keeps coming up. And so when I am noticing that my fuse is too short, to me, that is my cue that I need to, go out for a walk with the dog or schedule some downtime in some way that's reviving to me. And so I do think that's really important, self-care. Self-care is different for all of us and can come out in a lot of different ways, whether that's getting outside, seeing friends, something creative, just figure out what works for you, but it is really important.
Thanks for saying that, because they'll believe you. They won't believe me. So I needed to get a psychologist on it. It's like, it's okay to be angry. It's okay to talk to your friends about your anger. And it's also okay to look after yourselves. That's all. That's all.
That's it.
I wish there was some magic other
I-
thing that we
I
could come
know.
up with.
That's the secret of my field, right? It's not really magic.
Right.
Yeah, I know.
Okay.
Yeah.
Dang, no magic. Thank
No,
you.
there's no magic pill, no magic fairy dust, believe it or not.
Well, that was like a really amazing and important video. You know, like you said before, Britt, I definitely think this is the most important part of the live discussion today. It's certainly how we've all been feeling. You know, when COVID first hit, we were all scared. We thought we'd got through the worst of it and didn't think we signed up for like the Peter Jackson 2-hour director's cut, you know, edition for 5 years of continued like terror. We thought the Armageddon would be so dragged out and so painful for us to get through.
Yeah. It's been really challenging, and I think we've all had challenging experiences at work. I recently had the wait time in our waiting room has gone to hours that we've never seen before. And so obviously patients are pretty upset and really just honestly pissed off about that. And they take it out on us as the providers. You know, they finally see the doctor and they're just angry. And one of these patients, you know, I said I was sorry and politely reminded them that we're in a pandemic and we're really short-staffed and we're going as quickly as possible. And then her immediate reaction at me was like, oh, well, COVID's not real. It's just something the government made up. And, oh, and masking children is child abuse. So what are you all doing? And it makes it really tough to sit through that patient experience. And, you know, you want to, I hope to go to my next shift with some of these tools that Dr. Watson talked about. And I think, you know, self-care, whatever that looks like for you, or just taking a moment and having some time for yourself, and even just that breath before and in between patients can be really helpful. I don't know if any of the other EMRAP crew, if you've had similar experiences where compassion is running low. Anyone?
I think the answer from everybody before was yes. I'll try and explain one thing that might help. It's really hard for the general public to understand what's happening in the hospitals, what's happening in the ICUs. They go outside, they hear all this stuff on the news, and they go outside and the cars are going and people are walking up the street and lovers are being lovers and the dogs are barking and it's all good. And yet in the hospitals, you're being completely crushed and overwhelmed, and somebody even in the waiting room says, well, it's just a cold, and you'd like to just grab them and say, come and let me show you all the people that are dying a terrible death from just a cold. So there is this problem that they don't see what you see. I feel like we should have a live stream from the ER, from the ICU, of all of the death telling and all of the suffering there for them to have some understanding. So part of it, I think, is they just don't see what you see, and they can't understand it at the level that you understand it. So maybe if we understood that, we would have a little bit more compassion. But it's a little hard to have compassion when somebody takes a swing at you. Stuart, you had a story that was really disturbing.
Well, we've been hearing it. I mean, we've been hearing it from practitioners across the country, and you know, people are getting threatened. People are being accused of, you know, you're killing my loved one because of a therapy that you're using, or that you don't have access to certain therapies. I mean, we're really here. It's heartbreaking. You know, we've had a lot of discussions, and we had a discussion before tonight. What can we do? We have to do more. We have to do more to support our people. And these are cyclical conversations. And the only thing that, you know, that I can really take out of it at the end is that we're going to be here. We're still here, and we have each other. And that probably is the best thing going at this point, is that we have each other to lean on. And if we don't continue to talk about that, and if we don't schedule more of these when, you know, if it's necessary, that's a big problem, because then we stop the discussion. So that's one of the things we came up with, is let's keep talking together.
Yeah, I think that's such an important point, Stuart. You know, and despite all of these things, some bad interactions with patients or dealing with misinformation, like without a doubt, still, maybe I'm still got a lot of energy in my young age. It's like still the best job in the world for so many reasons, being able to be with people in their suffering and help them and know that you're going to be there. And I've just found myself trying to really remind myself of that joy that I get, even in the small victories, like putting in a shoulder on shift the other day, like something that I remember being so amped about like years ago, and through everything, still trying to find that joy and remember how great it is just to be able to help people and meet them where they're at, whether it's in a total denial CIA, 5G chip in my arm versus I'm about to have an end of life conversation with somebody without their family present, and just taking a moment and recognize like how like truly like a privilege it is to be there and to be able to have these discussions with this entire community online and to support each other and to brainstorm how can we best help people. It's truly amazing. You know?
Yeah.
Jan, you had a really good point about not all communities are the same, and so can you explain that to us?
Yeah, I mean, I hear stories about, healthcare providers, doctors approaching people about getting vaccinated and hearing all of this stuff about it's a hoax. And I know that it's out there. I'll tell you that where I work in East LA, which is a pretty low health literacy population, I see these conversations as an opportunity. Often they haven't had access to a doctor. They haven't been able to ask the questions. They haven't been able to express the things they're afraid of. And so, I still feel like we can break through and make a difference, but it's really different where you work. There's just different kinds of people in different places, and I get that.
Well, I think we should wrap up the official sort of presenting part. We'll keep the chat open for a significant amount of time and continue to talk to people there. I just want to say to all of you again, and I said this, when we did a live a long time ago, just look around at the people that you're working with. You are heroes. The house is on fire again. And you've already taken all of these babies and children out of the house before, and you're going back in again with your colleagues back in. You're this amazing group of heroes that are going back into the fire for like the 15,000th time. And look around at the people when you go to work. You're amazing. You're living through one of the most unique times in human history. There has never been in human history anything this infectious that has infected so many people at the same time. It's not going to make you feel better that there'll be books and things written about this and movies made for the rest of your life. Your great-grandchildren will ask you about this time. It is an extraordinary time. And all of you that go to work and see patients will be able to die, hopefully many decades from now, knowing that you did a remarkable job at one of the worst times in human history. You're all heroes. So I thank you. We all thank you. Thanks for your work. And we'll do more of these if we need to. Get your vaccines, get your boosters, and you're going to be okay. You'll get through this. Thanks, everybody.